If you would like to go out there to find the gaps in the care continuum of people who inject drugs, and specifically in the HCV field, you really have to go out there, down to the basement, and allow me the image, you have to go down into the underground. And this is exactly what Andrea Bregenzer did in the study of the Canton Aargau, together with co-workers. I see Peter Ackle here sitting. They just comprehensively analyzed in all people on opioid substitution what is the continuum of care, what is the cascade of care. And what they have found was really more than worrisome to all of us. But then Andrea went one more step ahead. She just proves that with relatively simple new approaches, it is quite easily to close the gaps. That will be one of the very encouraging messages today. Andrea, please present us our study.
Okay. Between July 2013 and July 2015, we have enrolled about 1/3 of all patients in the Canton Aargau receiving opioid substitution. There's a total of 630 patients. And of the 205 study patients, 24% have never been HCV antibody screened. Of those HCV positive, 19% have never had an HCV RNA test. And of the 61 patients with ever chronic hepatitis C, 20% had no HCV genotyping, 52% had no liver fibrosis assessment, and 54% had never received treatment. Of the 28 patients who received interferon-based treatment, a quarter didn't achieve cure. But there are still further gaps beyond the HCV cascade. 26% have never been HIV antibody tested, and the yearly screening of HIV negatives, HCV negative, and HCV antibody positive with negative HCV RNA was also insufficient. Only 20, 23, and 40% respectively had the test within the past year. More than half of the patients had known hepatitis A and B serostatus, and of those with known hepatitis A and B serostatus, 46% were not protected against hepatitis A, and 1/3 was not protected against hepatitis B. What are the potential reasons for these gaps? The first is difficult venous access after long-term intravenous drug use, fear of liver biopsy. OST programs are often exclusively led by psychiatrists, and thus somatic diseases, especially chronic infections, remain frequently unaddressed. And there's a lack of a yearly reminder regarding screening. Toxicity and low efficacy of interferon-based treatment explains in part the low treatment uptake. Referral to outpatient clinics of tertiary care hospital is often problematic because patients have difficulty keeping appointments. Until October last year, only patients with at least F2 fibrosis were eligible for treatment, thus only 1/3 could be treated. And until now, only gastroenterologists and infectious disease specialists are allowed to prescribe interferon-free HCV treatment. Within our study, we offered free HIV and hepatitis C rapid testing with capillary blood from the finger and non-invasive liver fibrosis assessment with FibroScan. The proportion never HIV screened could be reduced from 26% to 2.4%. The proportion never HCV screened could be reduced from 24% to 2%. And the proportion of patients with chronic hepatitis C without liver fibrosis assessment decreased from 53% to 1.5%. The HIV rapid test yielded no new HIV diagnosis. Remarkably, the last first diagnosis of HIV was in the year 2008. In contrast, hepatitis C rapid testing revealed 14 new HCV diagnoses, but also 10 false negative results. But these patients were all HCV RNA negative, either after spontaneous clearance or after early successful treatment, and thus these patients are neither infectious nor in need of treatment. And FibroScan acceptance was higher when offered in the same session, 94 versus 69%. Thus, patients seem to prefer a one-stop strategy. I have prepared two further slides showing how all the 12 gaps I have presented could be closed. In case of interest and time, I could present them after Claude Scheidegger's part of the talk.
Personally, I think that Andrea's interventional part of the studies is very, very impressive. This graph comes from another database, the SAMSU cohort, and what you see here are patients in opioid substitution programs in 8 centers all over Switzerland, and the columns represent each sum of patients registered in one specific calendar year. And first, in yellow, you see the first year of drug use in those respective patients. And in earlier years, this corresponds quite acceptable to the year of HCV infections, because in those times, people got infected within months of starting drug use. You see, there are several waves coming. After the first drug use wave, we have the red wave listing the first diagnosis of hepatitis C by serology. And then comes the blue wave with the first RNA detecting, proving chronicity of HCV infection. And finally, in green, the year of first treatment. And this piece of data has been analyzed by Andrea as well a couple of days ago, so you're the first to see this data. And what is the most important message in this graph is that it looks like, and this is what we see daily, it looks like that in this setting we are catching up in Switzerland. Trying to now discuss the gaps of care among opioid patients, among people who use drugs. One could list the topics and the issues the way we have here. At first glance, it looks like that everything is fine. With all the efforts done globally and nationwide under the lead of the Swiss hepatitis strategy, it should be that awareness is here. We already have heard that this is not the case. We have nice available drugs, easy to apply, without very, very strong secondary events, very good tolerance. And since 1 year we have universal access, we have the reimbursement by the health insurances, so it looks like, or it should be, that everything is okay. But of course, we wouldn't be here if this is really the case. So, coming now to the awareness, and as you see, I have placed this first in list because this is really the problem we have to face. We just see in everyday life that people who are infected, our patients and their healthcare workers, their physicians, they just don't think about the diagnosis. They don't perceive them having been, perceive themselves as having been at risk, maybe years and years ago. Or they consider alternative diagnosis, even if there are perturbed liver values, for example, because there is some concomitant alcohol use. So awareness is really still a problem. And then there are all those misconceptions around which really stick in the heads of the individuals, of the patients, of the physicians, of the heads of the institutions and organizations of our politicians. And these misconceptions can just be summarized. They are not true anymore. They are alternative facts. In terms of access, and more generally access with availability, with affordability, and allocation of public resources, we still have unsolved problems in those specific group of patients. And we will discuss that step by step this afternoon. And really, it is a shame that in such a rich country as Switzerland, we do not have the access for all those groups. There are still limitations for prescribers. We have heard that before, and there are many treatment obstacles. And I would like to put really this one first in place. Andrea already has put this on top of the list. In everyday life, this is a real problem. How do we get blood sampling? Because our patients in this setting of people who use drugs, they really fear this blood sampling. They had bad experience, they have really difficult venous access, and they just fear all those stitches. They also fear that when they get to the office, that first they are in contact with the youngest of the healthcare worker, and then comes the next, a little bit more experienced one, and then step by step they really are at the end of their patients, and they just get out. And that is what we live every day. So you really need to be a specialist when you will get some blood. Or you need to have one at hand. That's me after sunset. So watch out later this afternoon. Okay, but fortunately, we have alternatives. We can swab saliva to check for antibodies, so we don't need the blood for this one. We can use just a few droplets of blood to analyze the viremia and to check the success. So we have the techniques, but in this case, in the case of the swabbing of the saliva, it is not reimbursed by insurance. So there are still obstacles here around. Fibrosis assessment will be needed in the future, but you don't have to do the liver puncture anymore. It had been widely replaced by imaging techniques such as the FibroScan, or by a battery of some blood tests, such as the Fibro test, but this needs some blood taking and lab resources. So this is where we started when we treated patients with interference. And this is where actually we are. We have the techniques to take some droplets, do the diagnosis, do some treatment with panogenic treatments, and then to check the success. So we are somewhere in between here, and we have to try to get as closest as possible to this option here. So the question mark is, what is the key to get all those obstacles overcome? And I think the answer is readiness. And I'm really glad to have Jan Fehr here, because he did a great job in developing this concept of readiness in the HIV field. And Jan Fehr, we need you again back in the HCV field, because this is, I think, the key issue. We need to get people ready, and ready at various levels. We need to do more work for awareness for patients and for their healthcare workers and prescribers. And we need to get ready the institutions that care for these people. And we need more commitment and more readiness for the healthcare system as a whole, and also we need more readiness of our politicians. That would be my statement.